Hello all, this is Dr. Rupkumar. Welcome to another masterclass from Dentospedia. So today we are dealing with the final session in oral radiology, and today's topic is about maxillofacial cysts. And what is a cyst? According to Kramer, it is defined as a pathological cavity containing fluid, semi-fluid or any gaseous content, and it is not formed by the accumulation of pus. So it is completely different from the abscess. Okay, and if the cyst is having epithelium lining, they are called true cyst, and if they don't have epithelium lining, they are called pseudocyst. Okay, and based on its origin, okay, cysts are divided, are given certain names. So if the cysts are taking origin from the odontogenic epithelium or its remnants, they are called odontogenic cysts. Okay, and rest of the cysts are non-odontogenic. And here is a classification based on etiology. So these are the cyst examples related to the developmental origin, and these are the cysts taking origin from the inflammation. Okay, and coming to another important classification, here the classification has been divided based on the tissue of origin. Okay, there are certain cysts like periapical cyst and residual cyst taking origin from the rest of malacels, and these cysts are taking origin from the reduced enamel epithelium, and these cysts are taking origin from the dental lamina and its remnants. Okay, and there are few cysts named as unclassified, okay, because of their controversial origin. And this is the cross section of a cyst where you can see cystic lumen. This is a cystic epithelium, and this is a cystic wall. And coming to the important important cyst, that is called radicular cyst, and it is one of the important cysts in the odontogenic category. It is also called periapical cyst, also called apical periodontal cyst. It is nothing but a pathological cavity arising from the epithelial rests of malacels in periodontal ligament, and it is mainly triggered by inflammation from a non-vital tooth. So the non-vitality of the tooth might be contributed by caries or trauma or any complex restorations. Okay, and this is the most common jaw cyst among all the others. Okay, and it is commonly associated with the non-vital tooth. I'm discussing only a few important points. Okay, in detail explanation will be present in the Dentospedia app. Coming to the radiographic features, it is commonly located at the apex of the non-vital tooth. Okay, and it has well-defined cortical border, and sometimes dystrophic calcifications might be present inside the cyst. And few cases and also large cyst, there might be inferior displacement of the mandibular canal. And coming to differential diagnosis, it is hard to distinguish between radicular cyst and apical granuloma, but there are certain characteristic points like round shape, well-defined cortex, and greater than 2 cm size. And these are the three important points used for differentiating radicular cyst. And these are the differential diagnosis. An important test called vitality test is very essential for differentiating radicular cyst with another cyst. Okay, when we do vitality test for the tooth which is involved with the radicular cyst, the tooth will be non-vital 99%. Okay, and that's an important differentiating point here. And coming to the management, usually we go for apical surgery and then remove the cyst and also cystic lining, and then we have to do root canal treatment for the tooth. If the prognosis is bad, we can go for extraction of the tooth. Okay, and during the healing process, there is a pattern called spoke-wheel pattern. Here the new bone is growing from the periphery towards the center. Okay, you can see this is a spoke-wheel pattern where the bone is formed from the periphery towards the center. And here you can see the radicular cyst involving first molar, right? And this is occlusal view. And coming to the residual cyst, it is a cyst commonly associated with the previous surgical site. Suppose if we remove any radicular cyst in the molar region, and if you don't remove the cystic lining properly, and those remnants can give rise to residual cyst. Okay, and it is usually asymptomatic, and it might be discovered radiographically uh, in accidental exposure. Okay, and coming to the radiographic features, these are all common radiographic features which you commonly see in common cyst. Okay, coming to differential diagnosis, OKC and stiffness bone defect are kind of a, they mimic with residual cyst, so that's why we have to uh, clearly differentiate between these two. And coming to the management, we have to do surgical removal of the cyst, and if the cyst is larger in size, we have to do marsupialization of the cyst. Okay, and you can see these residual cyst appearing in the third molar region. Coming to another important cyst, that is called Dentigerous cyst, also called follicular cyst. It is commonly associated with the unerupted tooth, right? And it usually attaches to the CEJ, and is commonly associated with the third molars and canines because they are the most commonly impacted tooth. Okay, and it is usually painless. Coming to the radiographic features, it has well-defined cortex, curved border or circular border. Okay, and it is radiolucent in nature, and sometimes it can mimic OKC, ameloblastec fibroma, AOT. Okay, so we have to clearly differentiate between these two cysts, and we can go for histopathological examination to confirm the diagnosis. Coming to the management, we have to surgically remove the cyst and also tooth if the prognosis is bad. And for large cyst, we have to do marsupialization procedure. We have to confirm the diagnosis based on histopathological report. Okay. Here you can see there is a small follicular cyst. Here in this image, you can see a large dentigerous cyst associated with the impacted third molar. And then the buccal bifurcation cyst. It is also called mandibular infected buccal cyst, or periodontal cyst, or inflammatory periodontal cyst. It takes origin from the epithelial rests in the periodontal ligament at the buccal bifurcation of mandibular molars. So this is an important point. Its etiology is unclear, so certain researchers claim it as inflammation. Okay, and WHO classifies this cyst as inflammatory cyst. Okay, and coming to the clinical features, we can expect delayed or failed eruption of the mandibular first or second molars because of the cyst, and lingual cusps are protruding higher than the buccal cusp. This is an important clinical feature. Okay, and tooth remains vital in nature. And coming to the radiographic features, you can see a diagnostic hallmark, that is, the roots of the molar, they are tipped into the lingual cortex or lingually, and the occlusal surface is tipped buccally. Okay, and this is an important radiographic feature and also clinical feature. And these are the important differential diagnosis which you have to eliminate. And coming to the management, we have to curettage the cyst. If possible, we have to remove the whole contents. Okay, and tooth is preserved in few cases if it is not secondarily infected and there is no recurrence in this kind of cyst. Okay, and you can see this is a MIBC, that is buccal bifurcation cyst, or mandibular infected buccal cyst affecting the first molar region. Right, here you can see the tipping of the molars. Right, and coming to the important, that is keratocystic odontogenic tumor. And these are the synonyms. It is also called OKC, that is odontogenic keratocyst or primordial cyst. And WHO, it is reclassified this disorder, or we can say this cyst, as odontogenic tumor. Okay, and it has innate growth potential. That's why it has more recurrence when compared to other cysts. Okay, and it has tumor-like behavior. And The contents of the cyst is viscous and cheesy keratin material, and you can see it has high recurrence rate due to the presence of satellite cysts and residual epithelium. Okay. Coming to the radiographic features, its main location is in the posterior mandibular region. It has cortical borders unless it is infected secondarily. Sometimes it might have multilocular appearance. Okay. And it grows within the jaws with minimal expansion. Okay. It might perforate the cortex based on the size. Okay. And it sometimes displaces inferior alveolar nerve canal down to the mandibular body. Okay. In some cases, it might occupy the whole maxillary sinus. So these are the few variations in occurrences. Coming to differential diagnosis, these are the different cysts which we have to eliminate, okay, while diagnosing this condition. So coming to the management, we have to resect the tumor, and also we have to curettage the lining of the bone, right? And if the cyst is large, we have to go for marsupialization procedure. And because of its high recurrence rate, the patient has to go for multiple visits, and then we have to follow the case for at least 5 years because it has high recurrence rate. Here you can see the cystic lining, right, extending into the mandibular ramus. Here you can see the anterior posterior expansion of the cyst. So this is all about keratocystic odontogenic tumor. And coming to another important cyst, that is lateral periodontal cyst. It commonly arises from the epithelial rests of the odontogenic epithelium present in the periodontium. Okay, and it is usually unicystic. Sometimes they kind of appear in cluster form, and that kind of a variant is called botryoid odontogenic cyst. Okay, and it mimics lateral periodontal abscess. So that's why we have to clearly differentiate between these two. Coming to the location, it is present in the mandible, particularly in the lateral incisor, second premolar region, and in maxilla, lateral incisor, and canine region. And coming to the another important point, it is the tooth is vital. Okay, so that's an important differentiating feature, clinically and radiographically. And these are the differential diagnoses for this kind. Here you can see small cyst in between the two premolars. And coming to another important cyst, that is GOC, glandular odontogenic keratocyst. It is also called silo-odontogenic cyst. Why? Because why we are calling it as glandular? There is a reason for that, because it has salivary gland-like features like mucus-producing cells in that cyst. So that's why we are calling it as glandular odontogenic keratocyst. And it has a possible link to the central mucoepidermoid carcinoma. And it has slightly aggressive behavior when compared to other cysts. And usually the most common region is in the mandible anterior region, and in maxilla, the globulomaxillary region. And these are the important points regarding this cyst. And coming to differential diagnosis, these are the differential diagnoses which we have to look out for. And coming to the management, we have to go for conservative enucleation if there is high recurrence rate, and patient has to visit for multiple times to check for the recurrences. Okay, and periodic radiograph follow-up should be done. Here you can see multilocular appearances, right? Various cysts. Here you can see the multilocular appearance, the GOC. And coming to another important cyst, that is called calcifying cystic odontogenic tumor. It is also called calcifying odontogenic cyst, COC. and WHO it is classifies this as tumor. Okay, it is present in between the cyst and tumor spectrum. Okay, and they produce calcified tissue that is called dysplastic dentin. It is in few cases. And another important point regarding this cyst is, you know, it is kind of a normal cyst. Okay, there is no special points regarding in this cyst. These are the differential diagnosis. Okay, we have to enucleate and curettage has to be done. Okay, for every cyst, enucleation and curettage is a common procedure. And if we suspect there is high recurrence rate, we have to remove certain amount of bone surrounding the cyst. Here you can see the cystic lining. Okay, so that's all about the cysts of the maxillary region, maxillofacial region. And if you want more content regarding the cyst, you have to subscribe for the Dentospedia. Thank you.